setting. Can you all, is the screen set to where you see just my big slide? Is that right?
Yes,
Good.
exactly.
All right. So, this is obviously a PowerPoint from earlier, but it goes over all the same things. So,
Okay.
the concept of partial heart transplant is that we just take the roots, right? And so we've expanded it since to include a lot of different things, but roots are the first thing that this started with. And the original case here was, this is a nice family, and it was truncus arteriosus, right? So in the case of truncus, no matter what, you don't have an RV to PA root, but you do have a truncal root. But what if it's severe regurgitation, right? And you can't repair that valve? That's a perfect candidate for just needing a valve. They don't need the rest of the heart. And if you can just get a valve, it would be nice, but there's no bioprosthesis or mechanical valve that fits that size, right? At least here in the US, our smallest valve has a 15 millimeter annular size, and so it won't work in these neonates, right? So that's when we decided to work on the partial heart transplant. And so it's an aortic root replacement as well as some immunosuppression. Those two features together are what combine to make partial heart transplant. Obviously, the surgical side of it, we're used to immunosuppression and managing that from all our heart transplants. We do know that valves grow in the heart transplant position, right? If you transplant a whole heart, all the valves grow over the next 20 years with the child. But also the root replacements we're used to doing, right? With the Ross procedure or any other number of surgical adventures that require the root to be replaced. So here's an example of how we did one of these procurements. And so you can see here what it involves, right? You're taking off the RV to PA root on the right side, very similar to how you would harvest a Ross autograft. But simultaneously, the less common thing we do is harvesting the aortic root, right? Because very rarely in the surgical world do we take that out as a big piece, as in including the anterior leaflet, the mitral valve, and the left atrial dome, and the coronaries, right? They do it a lot for cadaveric roots that are going to be decellularized and frozen, but here, in this case, we need it from a fresh heart. So those are kind of the surgical preparation pieces. And you can see here, once we take those, we're left with what looks like two nice autografts, the same way you would thaw them if they were prepared commercially, right? You have a aortic root that's a little bit longer, and you have a pulmonary root that goes all the way out to the branches, and two good functioning valves.
Douglas,
Yes.
one question is, how do you preserve this heart? And which cardioplegia do you use or not? Which solution? And how much time is the time that you use this partial heart?
Great questions, all of them. So, our original ones were procured in Del Nido cardioplegia, which is how we transport all our full heart grafts. And so we'd use that as the preservation solution. Since then, we have a Duke solution that we've created that really the only important addition, I would say, is antibiotics, because we've found that we can do up to 3 days with these, 72 hours. That's what we've determined in the research lab, that these grafts are still viable. That's after studying viability in pig transplants. And so 72 hours is about the max that we would feel comfortable right now with knowing that these are still going to be viable. Now, what that means is that, over a 3-day period, you start seeing bacterial growth if there's any contamination. And so that's why we added the antibiotic solution to our storage solution. The longest one we've done in person was right at about 48 hours. That's the longest we've implanted so far, but we think that 72 hours is acceptable based on our research studies. Shorter is probably better, right? It would make sense that shorter is better, but if you're doing something like a distant procurement, you don't have that option. So then we go with 3 days is currently our maximum.
Thank you. Thank you very much.
We store them in a Sherpa pack, but anything in the 4 to 8 degree range, if we had a refrigerator here set up, we would transfer it to that just because it's easier than a Sherpa pack. But somewhere in that 4 degrees Celsius range is probably what you want for preservation. So, this was obviously featured in a lot of places because it was a new surgical technique. And, if you transplant both roots, then in theory, those will continue to grow with the child, right? And so that's where we've seen that data, and we have currently a lot of data that we've submitted to journals is publishing soon, in addition to our JAMA case report that shows that growth does occur over the next 2 years is the longest we have data from, right? I mean, we did the first one of these 2 years ago. And so there's other opportunities here, I think, for partial heart. And so we don't want to limit it. The living root is definitely the position that we think is the first, and that's the most easily adopted, right? We've had 3 other centers here in the United States that have done these so far. We think that that's the most definite application, but there's other places where implanting a prosthesis that can grow would be helpful, right? And so mitral valve, let's say you have a canal repair where the left-sided valve is maybe deteriorates over time and is not repairable. Well, it would be nice to put in something that will grow, right? Rather than putting in a mechanical valve that will inevitably have to change several times. And so that's one. Another application we think about is MAPCAs and small PAs. Well, it would be nice to have those to be able to continue to grow. And so I think there's other applications for partial heart transplant that's beyond just the living root position that we'll eventually be doing more of. Another application that's nice for a heart donation is that this increases the donor pool. So let's say you have a heart that either did not match with anybody on the wait list, or maybe it was unsuitable for donation because of ventricular dysfunction. Well, that heart still has 2 good valves, right? 2 good simulunar valves. And so here's me and another surgeon meeting at a place between us in the Carolinas where we exchanged a root. So we had one heart. We split the roots. One came to Duke and one came to Medical University of South Carolina, and each of them was then implanted separately. And so it's a good opportunity to increase the donor pool with the availability of the hearts that we have, because as we know, that's the limited resource, right? And getting these valves in small sizes is difficult. So particularly if you have a patient, a recipient that could do either the aortic or pulmonary position, it's nice to be able to split these up and double your potential donor pool.
Another question, Douglas,
Yes.
is you show ABO incompatibility, and do you use some protocol in the CV pump, in the cardiopulmonary bypass machine for this, or not? What do you do? And the other thing is, okay, this is the first question. Sorry.
Okay. So we treat it right now just like our standard transplants. So within the first year of life, ABO incompatibility, we don't worry about at all. And we immunosuppress with full dose immunosuppression for 1 month, or until they get to the age and size that we think that the valve could be replaced again if needed. At least you would have a backup. And so for some of our patients, that's 6 months. For others, it's 1 month. It depends also if it's in the RV to PA position or if it's in the aortic position, right? So the aortic position ones, we absolutely need those to continue growing. And so we maintain full dose immunosuppression later, even in an ABO incompatible model. Now, for patients that are older, it comes down to the decision of urgency, right? And so if it's somebody that you think could handle an adult sized conduit, let's say, then we want to do ABO compatible if we can. But if it's a limited, let's say it's a 3-month-old, right? They couldn't handle an adult size conduit, then we have done ABO incompatible in the smaller children, even in the RV to PA position, right?
But
because
do you change in the volemia? Do you change two volemias in the CV pump, or you never change the ABO group in the CV pump like an ABO incompatible heart transplant? Do you do something in the cardiopulmonary bypass machine or not?
Nope,
No.
we do not.
Okay.
We don't. We just yep, good question. We just do the full dose steroid, induction with it as well. But no, we don't change anything about the pump, because the del nido, I think, washes out the majority of the cells, and so the tissue reaction will be localized, is at least what we think. So.
And the other question is, the donors that you use, are the heart donors are good or are bad donors that you use for this partial transplant? How is the function of the heart?
Most have been bad. Most have been bad. So here, we have 2 categories, right? So one is a poor functioning heart that was never going to be eligible for a whole heart transplant. That's one category. Another category is a DCD NRP type procurement that didn't meet the criteria for being a heart donor in an NRP. So, this is somebody who had donation after circulatory death, not brain death. And it's a heart that then nobody was comfortable taking for an implant. And so that was a heart that was probably functioning good, but it didn't make the list of people who would accept DCD hearts. And so different category there. Both are possible. And we're also working on warm ischemia models because we think that these valves, since they're avascular, are probably will handle longer warm ischemia times than obviously whole hearts handle very little, right? I mean, 8 minutes of an NRP procurement is about all you get. But in a model like this, where the valve is probably less susceptible to it, we're trying to study to see how long people can have warm ischemia prior to harvesting the valves, because that would mean even situations such as you could, harvest a valve from somebody who had died hours ago, right, with the family and was on their way to the morgue or something. You could still harvest those valves, and if they would work well after implant, that would be great, right? Your donor pool would increase. But the thing that we're always cognizant of is infection, right, with the valves. And so if you otherwise, for some reason, wind up with a bloodstream infection or too long of a warm ischemia time, I think you risk that. But so far, they've all been fresh procurements from one of those two situations.
Which kind of antibiotics do you use for your preservation liquid solution?
We have vanc and cefepime that are inside of the solution in fairly low quantities, but that's just the preservation solution that we use.
Okay.
Yep.
Thank you. Sorry.
So, the domino heart transplant is something else that's interesting to talk about because we were just mentioning the donor pool, but the donor pool can be increased if you're at a place that does heart transplants, right? So here at Duke, we do more transplants than anyone on the adult side, and as far as 160 plus of them a year, those are all valves that are taken out, and the majority of them are good, well-functioning valves. So if you can transplant a heart, but then the heart you take out has good valves, we're able to take those valves and use them potentially for a living root situation, right? And so we've definitely done that even recently here with, let's say, a Ross, where you just need the RV to PA position, but you desire it to grow over time and self-repair, then you would transplant a valve from somebody who is getting a transplant. So we call that the domino heart transplant. And we've done several of these. Columbia's done some of these as well. And I think it's a really excellent example of organ utilization. Here's all the patients so far. Now, this list was only current as of 6 months ago. Since then, we've done 3 more, and I think Columbia's done a few more, and Boston Children's has done one as well. And so, you can see the list of diagnosis. The majority is truncus, right? And so it's the same indication that I was talking about. If you have a truncal valve that's leaky, you have these roots there at the bedside. You can either use both roots if the truncal root is leaky, or if you can repair that truncal valve, then maybe you just use this to reconstruct the RV to PA position. Both have been done numerous times. But also, if there's any situation where you have biventricular outflow tract obstruction, or some of these tetralogy with pulmonary atresia, those are good cases where you could do a living conduit in a smaller recipient and have it continue to grow over time and prevent these conduit changes down the road, at least until they get, adult size, where they have other catheter and endovascular based interventions. So, the FDA is now regulating this here in the United States. And so we're back online with it, and several other programs are as well, but there's a regulatory standpoint, pieces that weren't there before. And so those are things like, are we testing for Zika virus, for example? Is the donor tested for other things, hepatitis, COVID, exposures, right? So it's not being regulated like an organ. It's not through UNOS, but it is through the Food and Drug Administration here. So that's obviously different in every country, but somebody needs to be kind of regulating the use of these valves and make sure that the testing and the suitability of the donor is appropriate. In the research models, how we got here, right? So we were doing these in small piglets, about 8 kilos. We were transplanting the pulmonary valve position from one pig to another. And this is what got us to this position of knowing that these were going to grow and they were going to take, is that, we did these heart surgeries in the pigs, and then we just watch them down the road. Pigs double in size over the next couple months. And so we were able to see that as the pig grew a lot faster than a human does, that the pulmonary valve annulus and all the tissue around it not only grew, but it continued to work well. as opposed to what you would expect out of a cadaveric conduit, which is that it will shrink over time. So here we are doing some of these piglet heart surgeries. You know, we take out this, we put it in the normal pig, and then here's our reconstruction, right? Just the same way we do in humans. And so it winds up giving us a lot of data. And that's still the model that we're using to test cold ischemia times, warm ischemia times. We're doing this with tricuspid valves in pigs as well. And so we're really trying to kind of find the boundaries and the limits of what parts of the heart can be safely transplanted, and then seeing if it grows. Some of the new, more interesting things we're doing is a donor from, let's say, a male pig into a female recipient, and then we'll do fish studies and see if the endocardial lining that forms is of the XY or XX genotype, right? That's what helps us decide if it's a lining that covers it or if it's viable cells still of the actual donor graft that are functioning. And so we're trying to prove all this scientifically, that the grafts are in fact viable and that they're not just dilating over time, and that's what's making them larger. So far, everything points to they are viable and they are still actually living grafts. We see that too with some GFP studies. So another way, in addition to the XY, is that we can use GFP donor pigs. And so special pig tissue that can light up with fluorescence. And we can see that as those cells are still alive at the end of the study in the explant, that they're viable, right? They're still glowing. So clinical patients, we, this data is getting published soon. And so all these graphs are showing growth along the curves, which is awesome to see, right? We want them to stay within the respective Z-score. Some that we put in were bigger than they would be expected to be, particularly RV to PA graphs, right? We're a lot more lenient on how big those are, but we just want to see that they're all continuing to grow, because you know that the decellularized homografts are going to be shrinking over time, and we see that. So if this tissue can continue to grow and self-repair and not calcify, then we think this is a great therapy. And so far it has been. Like I said, we have 2-year data now on a lot of these. So the next few things we're doing, you know, we've accomplished this. We navigate the FDA tissue requirements. There's only a few centers that are signed up with the FDA with the appropriate testing and also follow-up that's required for that particular regulatory institution. We do have clinical trials and grants that we're setting up with this to study the clinical patients and see, is this actually better than the decellularized homograft? Now, if you can show growth, it kind of is. If you've done enough, decellularized work, you know that that's going to be true. But we, of course, want to prove it scientifically. And so that's why we're doing this. And right now, I think it's a great therapy for all, particularly pediatric patients that are pulmonary atresia, anybody getting a Ross in the first couple of years of life. I mean, anytime you can prevent that serial conduit replacement, I think this could be a great therapy. The question is always how much immunosuppression you're using and is it life-altering or not, right? So we've decreased a lot of these patients. We've had some where we had to stop immunosuppression because they had mediastinitis. Well, those valves are still growing, which is amazing. Some of the other patients, we've dropped down to half-dose tacrolimus, which is not really life-altering therapy. A lot of people use it for autoimmune diseases. And those grafts are still growing as well. So I think that's something that we're still trying to sort out with our pig model and with the humans that we've transplanted so far, is what is the optimal duration and amount of immunosuppression? Because that's really what is different about these than if you were to use a decellularized homograft. So I got some time here, I think, for questions, if anybody has any for me.
Yes, of course. I want to invite someone in the audience has any question? Anyone? I have some questions more.
Okay.
But I don't know if someone want to ask any question.
I can pull up a video too here that I think people might like.
Okay. Do you have a protocol about this? I know in the news you use a mitral valve too in a little boy, no?
So the protocol that we use is, you're asking in terms of like who we would use it on, what diagnosis, who do we think the optimal candidate is, or?
Yes. How is your training to use these different homograph?
Yeah, I think in our mind, the patient that we want to have it on is any that we think that there's a chance that the valve is not going to be repairable. So in truncus, let's say it's mild insufficiency. Well, if we had one, it would be great because we would use it for the RV to PA position. If we don't have one, then what we will do is, proceed with that repair. If it's moderate or severe insufficiency, we really try to get a set of roots as a donor here. Now, logistically, that's challenging right now because there's no system set up across the nation that equitably allocates these roots. So right now, if I have a patient that needs a truncus repair next Tuesday, unless we happen to have somebody nearby regionally here, I don't have any way of finding a route in, let's say, California across the country. We're trying to develop that system because I think once we have that, any truncus repair, any neonatal operation that needs a conduit, we should be giving them a living root. All the evidence supports that it's better.
But my question, I have 2 or 3 questions. One of the question is in the animal study that you show in your research model, the pigs duplicate the weight or wing in the first 6 months of the life of any pigs. They develop 6 or 100 kilos. And this is a very nice concept to show if the pulmonary artery that you transplant grow or not. This is the reason that you choose the pigs to show the growth. And this is the first question. You show a different growth factor in the study that you show. And the question is the immunosuppression that you use is a little immunosuppression. It's not a high immunosuppression, no?
That's right. So for the first month, it involves steroids, tacrolimus, and then eventually we wean down just to tacrolimus. So CellCept and Tacro is always our heart transplant immunosuppression regimen. And so we modeled our immunosuppression for these off what we use for full hearts. Does that answer?
Yes, and the other question is in the literature, when I am looking the bibliography, I find an experience from Magdi Jacob in UK in the 90s, and he did this strategy about these kind of donors and how he used, and the problem was the infection, the endocarditis that he had in his patient. Do you had or did you show something about this? Did you see something?
Yeah,
About
good question. Yeah, I mean the home of vitals data were all, the thought of doing this from Madhya was in a different scenario where they weren't using immunosuppression, they weren't as freshly procured, and they weren't trying to show growth. And so that aspect of it, you always wonder if you don't immunosuppress initially, if there's a combination of infection that occurs with rejection, right? Which I think could happen, particularly if your procurement technique it isn't sterile or isn't as immediate. And so that's always worrisome. We have not seen endocarditis in any of these yet. It's certain something we'll obviously be on the lookout for. There's several different RV to PA positions, right? Contegra that also can have endocarditis. And so we'll keep an eye out for that, but we haven't seen that so far at all.
And when you begin with the immunosuppression, when you open your aortic clamp, you use corticosteroids and another drug or not? When you begin with the immunosuppression?
That's right. Steroids at implant. Yep. Just
And
like
when
we do
you
for heart graft implant.
and when you change the drug?
To when do the steroids taper off? That's over the next week, and then it's on to a CellCept Tacro as the regimen.
Okay.
And that's for a month minimum, and then CellCept drops off. Tacro goes to half dose usually. Now, like I said, the circumstances can change because if it's a systemic valve that you need to last longer, we sometimes have been more conservative about resuming full dose immunosuppression for longer. So it is patient centric.
Okay, I want to ask Dr. Neirotti. He's a surgeon. He's retired now, but he worked in US and Europe and Argentina too. And Dr. Neirotti, what is your opinion about that? Are you mute? Are you mute? Can you? Estás callado, Rodolfo. Estás callado. No te puedo escuchar. Estás silenciado. No te puedo escuchar. No, tu audio no sale. No sale tu.
I think it's okay now.
Yes, it is okay.
Well, I mean, it's an interesting presentation. I'm not sure what the number of cases has been done.
How many?
Yes.
We've done 13 of these.
13. Okay. Well, then it's an interesting approach, but 13 cases are not really representative for what is going to happen afterward. You know, and that's something that is very important, that we follow up this patient, and before you recommend this, have a sufficient experience before you get other people involved in this kind of experimental surgery. Experimental surgery is something that has to be done when it's something that has been proved previously by a very exhaustive examining of the result. You know, that's something that has to be, in my opinion, careful when one start doing a long number of cases with a low number of patients. I mean, and then I haven't seen any numbers that convince me about it. You know, the numbers are small. So I think that's something that had to be carefully considered. The numbers, you know, that you have, the number of cases that you have done is the result. You know, before you embark them in something that you don't know what is going to happen.
Okay.
Yep.
Very good.
Yeah, I think that's a great point. I agree with everything you said. We
Douglas?
don't, we won't have more numbers until we do more of these. And I think that the important part is that certain applications, they don't have other good options, right? So a truncus with severe insufficiency, the mortality rate with the valve repair going into that over the first 30 days is still around 40%, right? And so unless you are at a place that has better results somehow with homograft root replacements that are non-living, then, you know, that's the baseline that you're comparing it against, right? And so that's why we start with uniquely difficult, high-risk patients that don't have other good options, right? And I think those are the ones that benefit from this the most. People who have no good simular valves and they need 2 of them. I think that's the best application. The other ones, you know, if this continues to work well and it's proven, then obviously the comparison is what's going to be important. But the baseline for a truncus with severe insufficiency, that's a very difficult case. And so I think that it gives you options as a surgeon that you wouldn't otherwise have.
Well,
Okay.
this is clearly an experimental presentation, and that had to be reinforced by numbers of on before using that in many patients and without that information.
Douglas, one question is, you didn't see any endocarditis, and all of your graft grow, no? Duplicate or increase the size.
They've all grown. Yes, that data is in review in the New England Journal, so you'll see it come out probably in the next month, I would guess. But yeah, I mean, all of these have a growth curve that has continued to grow. There is, sometimes the only negative effects I think we've seen so far is that the distal branch pulmonary arteries in truncus can be small. And if we can still have problems at the distal where this connects to the small pulmonary arteries, right? That's true in any truncus situation, but that's the only place where we've seen a reoperation.
And the other question is, how you did your operative technique when you use this graft? You use a continuous suture?
Well,
Or
perfect.
you
Let me,
use-
I have a video here. Let me see if I can share it real quick because I have one here. Sorry, I didn't get more time to prepare for this, but I have a video here that I can show you. Let me swap these.
Yes.
Whoops. All right, can you see my screen?
Yes, very good.
All right, so this should show us parts of the operative technique as long as this video plays. Hold on. One sec.
Okay,
It's not playing yet, huh? One sec.
no problem.
There we go. All right, can you see it now?
No, I only see your PowerPoint, not the video.
Okay, hold on. All right, it is playing now. Is this screen, or is it still the PowerPoint?
Yes,
You can see it?
the PowerPoint, not the video.
How about now?
Yes, now, yes. Very well.
So here we go then. Let me show it on this one. So this should be a video of one of these that we did. So here's the root preparation. Tying out the coronaries. They're separating the two roots. So we went through we made 3D models of truncal hearts, and we were trying to figure out if we should do them together, sew them in as one double root with the conus, or if we should separate them. And it's actually easier to separate them because you have to do the VSD repair and all as well. So we found that separating them was better.
Do you use aortic graft from both root replacement? Or
In
you,
general, we've put in more aortic roots than pulmonary just because we found that we need that extra length.
okay,
But that's because we're either doing most of these, if they're just the right sided, it's either a truncus or it's a pulmonary atresia, and so we need the extra length.
okay.
Is the reason for that. But the pulmonary graft we used for example, a Ross, the last few Rosses we've used pulmonary homografts.
Here is you open the outflow tract.
Yep. So we float it down like this as far as just like a Ross, you know, putting your buttons. We're able to use the mitral leaflet for the VSD closure, which is saves you from having to do a separate patch, right? You just sew it along the VSD whenever
Okay.
we're reimplanting there. So that's the systemic outflow position. It's going to the VSD, it's going to the proximal. And we just run it, it's just like any graft. You float it down and in, and then we figure out where the two buttons are going to go. Drop in the buttons just like a Ross. Here we're figuring out the distal length.
Do you use a running suture?
Yeah, we use running for everything.
Okay.
But it's a 6-0, so it stretches and breaks over time. Here's the buttons going on. This is just the distal, of course, and now we're working on the pulmonary side, and so both homografts go on. That's why people have called it a top half transplant as well, right? Both simulator valves, the whole top half of the heart is what's getting transplanted, but nothing that has ventricular function. And so there is a muscular skirt there. We don't leave as much of that anymore, but there is always going to be some of it that you're sewing to, and that can lead to some interesting findings, like if you're testing cell-free DNA levels, or people wonder what would happen with that if it necroses or rejects in any capacity. But we so far haven't seen any problems with that. So there's that video. Juan Miguel raised a hand, it says.
Do you have a video about the mitral graft that you use?
Oh, I do. Let me find one. Well, I have one from a pig. I don't have one from a, let's see. Okay. It's still good though. Let me find it.
Yes, I wait for you. I like your movie.
I just got to find it here. Sorry, these are all in the midst of many other. So we do heart thymus grafts here too. We do an RP. Let's see. Let me find the last one. One sec here. I'm going to stop sharing for a sec while I figure this out. One sec. Sorry, guys. I just got to find this. Transplant. All right, here's one. So here's the one we did in a pig. Let's get this going. So can you see a video?
No, I see Garraham.
Oh, there you go. Good. I'll move it over here.
Yes, now yes.
I was trying to get to your all's link earlier. Sorry about that. But here's a video of the one we did in a pig. So
okay.
The question is always what
we show proof of concept for mitral valve partial heart transplantation. So on the oral back table, the donor heart is secured in the sterile field with the left atrium posterior, similar to the orthotopic position. Right?
Oh, sorry, it stopped here.
No, it's okay.
The fossa ovale is also identified for the septal incision to create a window into the left atrium. And for better exposure of the mitral valve, stave sutures are applied above the mitral annulus to lift the mitral apparatus higher into the left atrium. Dissection of the mitral annulus is then performed with the periannular incision starting above the anterior leaflet. The dissection is then extended circumferentially until the annulus is completely detached.
You use the subvalvular apparatus.
Yeah, we bring the papillary muscles with them, and those are what we reimplant, which is
Okay.
easier to
Once
do
the
if it's a
annulus is
mitral
completely
transplant,
detached,
of course,
the
than it, you know, the
papillary muscles are
tricuspid
identified.
has all these
And then the
fronds,
longitudinal
right? So it's a
node
lot more
is harvested
difficult.
ample tissue for implantation.
Yes.
So here for subvalvular, we take the pieces of the PAPs, and those are what we sew down to reimplant them. There it is.
The explanted mitral apparatus is then inspected and placed in ice. as
And
a
how you
recipient
implant
implantation.
the head of the papillary muscle.
Well, we just sew them on with, you know, pledgeted sutures. So
In a similar manner, the recipient heart is
the same
affixed
way
to
you'd
the sterile
reimplant,
tube.
you know,
The right atrial window is kept
crossing
open with
cord
four
in a
sutures.
complex heart.
The atrial
Okay.
autonomy is performed to access the mitral valve.
This is very good. Do you use this technique in Sean patient syndrome?
We haven't yet. Dr. Narati was talking about experimental. This is experimental here. We haven't done this in a human
Yes.
yet, but we, you know,
Now,
someday. We just want to prove that the technique works, and we have to show that these grow in pigs first, right? And that they engraft and they don't fail miserably, because I'm not sure about the blood flow to these, right? It makes more sense in the semilunar position, because we know Ross's engraft and grow, right? But this is different here because the annulus is also avascular. The pap muscles have to engraft and stay invascular. So I'm just not as sure about this one yet. But
Okay.
I would love for it to work, you know? We need to prove that it does before we're able to really have a good reason to do it in a human.
This way, the valve is implanted.
But I'll show you the rest of the video here. It actually floats really nice at the end, you know, so that's one indicator that it could work. But long term, who knows, right?
Yes.
Only one set of pledgeted sutures are shown for each papillary.
Congrats for that. We have a question from someone show his hand. I don't know who is in the audience.
Hello.
Yes.
Hello. This is Juan Miguel Gil Jaurena from Madrid, Spain. First of all, thank
Okay.
you for the invitation and congratulations on this amazing milestone. I've got a couple of questions regarding the ROS procedure. As far as I understood, when you perform a ROS procedure in this particular setting, you carry out a regular pulmonary autograft in the aortic position plus a partial valve transplant in the right side. Is that correct?
That's right.
Yeah, and would you consider, instead of this whole ROS, to transplant partially only the new aorta in the left-sided position, keeping the right side in place?
Absolutely. And we've done that in kids that, you know, so Ross outcomes younger than age 2 or worse, right? We know that. And so we've done that where we want to preserve, you know, you get one shot at a Ross, right? You get one Ross.
Okay.
And if you mess it up, then the pulmonary valve's gone. So we've done that before when we happen to have a living homograph for the aortic position, and it's a younger kid who's less than age 2, then I think that's a good application of you put it in the systemic position, grow the kid, see how well it does, how long it lasts, and then do the Ross if that fails. I think that's one good way to do it. We're just not, you know, it depends on your confidence level, right? If your confidence level, if we have long-term data to prove this, which we will, then I think you would say, why would you ever interrupt the right-sided position? Why not just put all these in the left? And I think we might get there. All the ones that we put for critical AS babies in the systemic position are still growing and working really well. But it's really hard to prove that, right? Across 20 years, whenever we started doing them, 2 years ago. And so for now, if it's a kid who's, let's say 2 or 3 years old, we're not going to have 20-year data for another 18 years, right? So I think in those people, you want to give them the Ross outcome whenever it's optimal. And for me, that's anybody over age 2.
Okay, thank you. I mean, the rationale could be just keeping the ROS as a latest procedure, just
That's
in
right.
case.
That's the only reason.
And as going through your chart, I think I saw that you keep the left partial heart transplant, I mean, the aorta for the left side and the pulmonary root for the right side. Would you consider swapping, I mean, placing a pulmonary partial heart transplant in the left side position or the other way around, like a regular homograft?
Yeah, I don't think that it matters as far as which you're putting it. The length of the conduit is what we found in these small kids is what matters. You know, now older kids, you worry more about the thin PA and whether that's going to dilate or leak or become aneurysmal. But I don't think in the young kids that matters. I think what matters is, do you need the length of the aortic conduit with the arch and the curve, or do you not need that? And if you don't need that and you just need a short segment graft, then it comes down to what's going to be the better size match for you. And the pulmonary side is always going to be a little bit bigger, usually 20% or so than the aortic side. And so if you have a size mismatch, which you always will, because, you know, we just don't have that many grafts available, then which one's going to be the best size?
Okay, and may I have a last question, please?
Of course.
Yes.
Regarding that domino procedure in which you carry out a regular heart transplant, and from the recipient, you harvest the pulmonary and the aortic root as a partial heart transplant. Would you schedule these second transplants, the domino one, the day after? And in that case, I mean, if you don't have the logistics to carry out 2 simultaneous heart transplants, and if you delay the second transplant, how long would be comfortable for you, and which kind of solutions with or without antibiotics would be useful for that?
Yep.
Thank you in advance.
Of course, yeah, good question. I think that we usually schedule it for the next day. We try not to interrupt, you know, too much of our elective schedule. A lot of these patients, if they're TET pulmonary atresia or Ross's, they're coming from home. And so you have to give them time to mobilize and get here and all, right? And so we usually schedule it for the next day. We store it in Del Nido that has antibiotics, but, you know, it's just I think preservation solution would be fine. That just happens to be the one that we use here most commonly. Our adult team uses HTK. That's probably fine as well. But the key being that, you know, you're in a preservation solution, you're at the right temperature, and it's less than 48 hours. That's what I think we would prefer. Our data shows 72 is okay, but there's really no reason to wait that long unless your, you know, recipient can't get here or something.
And any issues with an extra doses of antibiotics in that solution?
You know, we've had them in there and we haven't had issues with that, if that's the question. We use similar antibiotics for a lot of our pump priming or for ECMO solutions as well, if we're doing NRP. And so that's kind of where some of the protocol was developed from. But I'm not sure that it's necessary. You know, we don't do it for other grafts that we preserve, let's say like kidneys, for example.
Okay, thank you, and congratulations again.
Thank you.
How many days the patient receive antibiotics after the surgery?
So we have an open chest protocol. If it's a neonate and they're going to have an open chest after the operation, which most of our trunkus do, then those antibiotics last 3 days after chest closure.
And can you repeat the doses and the antibiotics that you use in the solution, the needle preservation?
Well, it's vancomycin. I don't have the doses offhand because we mix it up in 4 liters. You know, the Sherpa pack is what we use to transport these and to store them. And the Sherpa pack keeps them in that optimal temperature range and reports back what they are. And so we mix it in a big, you know, 4-liter batch whenever we're making these.
Okay. Okay, thank you, Douglas, a lot. This is a very nice presentation. For the audience, next Friday, we have Luis Quiñones for the lateral tunnel lecture from Boston Children's. And okay, thank you again, Douglas, for
of course.
your lecture. Bye-bye.